Good morning, everyone. Today we'll be studying a very important topic in the subject of radiology. So, before we start, I want to ask you all a question whether a dentist is one's own radiologist. Does this stand true? Of course it does, because irrespective of which branch you belong to, it is imperative for all of us to know how to make a basic radiograph, that is a basic intraoral dental radiograph. So in today's lecture, we will be studying a technique to make an intraoral dental radiograph. The technique is called bisecting the angle technique of intraoral periapical radiography. I will be covering the topic under the following headings, that is the basic radiographic process, types of intraoral techniques, and bisecting the angle technique. Before we start our actual topic, we'll do a quick recap of what we've actually already studied about the production of X-rays. So we've seen that X-rays are produced by controlling the quantity and quality of the X-ray beam. We direct this X-ray beam towards the object. The object in our case is a tooth. Then this X-ray beam, it interacts with matter. Any substance, every substance is made up of matter. So here the X-rays are interacting with our teeth. Then there's differential absorption of the X-ray beam, which casts an invisible image pattern which is captured on an image receptor. Whenever I say receptor in this chapter, we will be referring to an intraoral periapical film. The same thing that we just learned, quality and quantity controlled X-ray beam is projected on an object. There's penetration and differential absorption of the X-ray beam, and then an invisible image pattern is cast, which on processing is developed into a beautiful radiograph. Now remember, radiographs are to be made only when benefits from them far outweigh the damage from radiation exposure. Now we'll take 2 minutes to try to understand what this sentence means. It means that it's absolutely important to know when and where we should be using a radiograph. X-rays are not a luxury, and you shouldn't expose yourself or the patient whenever you want to. So if there's an intense need, then only we should be heading for a dental X-ray. There are 3 types of intraoral radiographs: periapical, bite-wing, and occlusal. We'll concentrate on the periapical part today. Any radiographic technique is described under the following headings, that is patient position, placement of image receptor, direction of the central ray, the centering point, and exposure parameters. Intraoral periapical, the word itself says intraoral. Periapical is around the apical structures of the tooth. So this projection is used to record images of teeth, periapical and periodontal alveolar bone. The 2 techniques of intraoral periapical projection are paralleling cone technique, also called as a long cone technique, and bisecting the angle technique or the short cone technique. Now we'll start our actual topic for today, that is bisecting the angle technique of intraoral periapical radiography. This was first described by Weston Price in 1904, and it was independently described by Szynski in 1907. That is why it's also called as a technique based on principle of isometric triangulation given by Szynski. Now Szynski's rule of isometry, it states that 2 triangles are equal if they have 2 equal angles and share a common side. So Szynski's rule is the principle for our bisecting the angle technique. We'll see how we're going to apply it in our technique. Now describing the technique, first is patient position. For this technique, we'll make the patient sit upright in the dental chair with the sagittal plane perpendicular to the floor. For maxillary teeth, we'll have the ala tragus line parallel to the floor, whereas for the mandibular teeth, we'll have the lower border of the mandible parallel to the floor. So you'll have to ask the patient to slightly tilt his head up for the mandibular projections. Second is placement of the image receptor. The image receptor is the film. It's always kept on the lingual side or the palatal side of the tooth. It's placed close to the teeth, making an angle at the occlusal level with the long axis of the tooth to be radiographed. It extends beyond the occlusal plane by 5 millimeters. Its position is maintained either with patient's finger or with a holder. What we just said. This is the film or the image receptor that is placed on the palatal and the lingual sides of the tooth. Also, it is in contact with the teeth near the crown, and a safety margin of about 5 millimeters is kept. Now we can also use a finger to hold the film, or we can use film holders. Types of film holders are artery forceps and snap array instrument. Snap array instrument is the one that we specifically use for this technique. We used to use artery forceps and needle holders, but this instrument makes it really easy even for the operator to place the film into the patient's mouth and even for the patient to hold it stable. So it has particular slot for film placement and also a bite tab or a bite block on which the patient can easily bite, and hence the film will be stabilized. We saw the patient positioning, we saw the placement of the image receptor. Now moving on, we'll see the direction of the central ray. By central ray, I mean the main X-ray beam that is going to pass or that's going to expose the object, that is our tooth. Now in this scenario, these two red lines, they're depicting the long axis of the tooth and the long axis of the film. Now we will make a scenario in which we see that a central ray is perpendicular to the long axis of the film. In this case, what will happen? The image size will be smaller than the object size. So there's a discrepancy. That's what we don't want. So moving ahead, we'll try another scenario in which now we're trying to keep our central ray perpendicular to the long axis of the tooth. And neither that is working well for us, because here we see that the image size is greater than the object size. So to get rid of these discrepancies, we're going to find a midway solution to this problem. So hence we drew an imaginary bisector and we kept our central ray perpendicular to this imaginary bisector, because of which we got two equal angles and one common side. This is how we are going to apply Szyszewski's rule of isometry in our angle bisecting technique. By doing all of this, we got the image size approximately equal to the object size. Next, direction of central ray we saw, it's perpendicular in the horizontal plane. So when the central ray is passing, there's no horizontal angulation. But what about the vertical angulation? So the angulation for maxillary teeth is positive angulation, and for mandibular teeth it's negative. For maxillary teeth it is 40, 45, 30 and plus 25. All these are positive. For mandibular, starting from molars, it is minus 5, minus 10, minus 20 and minus 15. This was about the vertical angulations. Moving ahead to the centering point or the point of entry. We spoke about the horizontal angulation and the vertical. We also need a third dimension, that is a centering point, that is going to give us an idea about where exactly we are going to suppose to place our tube head. So point of entry is along the ala tragus line for maxillary teeth and along a line 2 centimeters above the lower border for the mandibular teeth. So for maxillary teeth, for the central incisor, our centering point is the tip of the nose. For the lateral incisor, it is a line that is passing through the ala of the nose. For the canine, it is a line passing through the inner canthus of the eye. For the premolars, it is a line passing through the interpupillary line. And for the molars, it is a line passing through the outer canthus of the eye. Similarly, for mandibular teeth, we have, for the incisors, it is the tip of the chin. For lateral incisors, it is the ala of the nose. For the canines, it is the corner of the mouth. For premolars, it is the interpupillary line. And for the molars, it is a line passing through the outer canthus of the eye. So this was our centering point. So we exactly know how to make the patient sit on the dental chair, how to place the film. We've also adjusted our horizontal, vertical dimensions. We also saw to the centering points. What is next? We have to shoot and make an exposure and expose the tooth. For that, we are supposed to know the exposure parameters. Exposure parameters for this technique include a kilovoltage peak of 65 kVp and a milliamperage of 10 milliamperes. The time could vary in seconds, but for this technique, it's usually less than 1 second. Then TID means the target to image receptor distance. We'll keep it about 20 centimeters. And the size of films that we are using is E-speed, that is fast speed, non-screen films, number 1 for anterior teeth and number 2 for posterior teeth. These were the film specifications. Now since we've done with the technique, now we'll see to a certain limitations and advantages of this technique. Limitations related to image quality include poorer image quality with size and shape distortion. Then detection of early caries and early periodontal disease might not be possible always, and the zygomatic process of maxilla mostly superimposes over the periapical region of maxillary molars. The limitations related to radiation exposure are it's more exposure due to a shorter TID, more vertical angulation and the patient in upright position. The advantages of this technique are it's easy to master, easy to practice, does not need special receptor holders. So in a mass practice, it's always easy to perform this technique because you will not need a special image receptor. Also, it's less time consuming compared to the other technique and easy to perform. These are the advantages. Now since we've summed it up, we'll just quickly revise what we studied today. We started with the basic principles of radiology, how an image is produced. Then we moved on to the types of intraoral techniques. So bisecting the angle technique, we will be describing under a few headings. Before that, we saw that the principle of bisecting the angle technique is given by Szynski, also known as Szynski's rule of isometric triangulation. Then we saw the patient positioning, placement of image receptor, centering point, horizontal and vertical angulations, and the exposure parameters. So I want you all to write a brief note on Szynski's rule of isometry and also a detailed description of the angle bisecting technique. I've put up pictures of the textbooks that you all are supposed to read from so that you know where you're supposed to study this topic from. These are our radiology textbooks. Thank you.